That's okay.
Warm welcome to you from Geneva, Switzerland. I'm Reda Sadki from the Geneva Learning Foundation, and I am here with 4 experts from the International Vaccine Access Center, known as IVAC, with Bill Moss, the director, and colleagues Kyla, Hayford, Andrea, Carcelan, and Christine Prosperi. Today we are speaking about the 4th episode here around the topic of serosurveys, and today we're looking at alternatives to community-based serosurveys. And I hear one person who has noise in the background. I think it is Charlotte. Charlotte, how are you doing?
Thank you, Reda. I'm doing great, and it's great to have our experts from IVAC with us for this 4th day of this journey that we took upon on serosurveys.
Great, thank you. All right, let's dive in. First, we need the reminder from Bill Moss, the director of IVAC. What exactly is IVAC, and what are you doing what have you been doing around serosurveys lately?
Yeah, thank you very much, Rada. And we're very excited to conclude this mini-series on serosurveys. The International Vaccine Access Center is based at the Johns Hopkins Bloomberg School of Public Health. And we're a multidisciplinary team that has as a mission to accelerate global access to life-saving vaccines through the development and implementation of evidence-based policies. And some of us, Rada, at a small team of us at IVAC have been working on serosurveys to better understand their utility and feasibility. And we're really excited to share with your audience some of what we've learned over the past several years in conducting serosurveys in Zambia and in India.
Great. Okay, great. And I believe one of the things we want to highlight, if you're joining this live session now, is to go look at the serosurveytools.org website. In addition to listening to this mini-series and learning more, if you want to go further, this is probably, Bill, would you agree that this is potentially probably one of the best resources available online about serosurveys?
Yes, Rada, thank you. And there are documents out there. The World Health Organization has produced documents, but what we've tried to do is really make learning modules and provide tools for people who are interested in learning more about serosurveys and actually conducting serosurveys.
Great. And I just want to acknowledge some of the folks who are joining us online, such as, let me see, Abu Bakr Mohammed, who is joining us from Nigeria. Welcome to you, Mohammed. And without any further ado, let's dig into the questions. So Charlotte will take us first through a Q&A, and then we are keeping an eye out for comments and reactions. There may be a technical glitch today that prevents us from looking at the comments. So please let us know you're there. Type in the city and country and share your questions as soon as you have them. I see we may be recovering from the technical glitch because I see messages from Ahmed Sangha and from our very own Dr. Tanushri Mandal from the COVID-19 Peer Hub. So Charlotte, over to you to walk us through the questions for today's episode, fourth and final episode in this mini-series on serosurveys.
Thank you very much, Reda. My first question is addressed to you, Kyla. And why would you choose not to do a community-based serosurvey? For the past few days, you have been talking about community-based serosurvey. So why would you choose not to do that?
Thanks, Charlotte. It's great to be back. And as we talked about yesterday, there are lots of challenges to community-based serosurveys, but I do want to highlight that if you want to get a representative estimate for your population with the least bias, then the best way to do it is with a community-based serosurvey, if you do it well. Also, another strength is that you can collect specimens in a community serosurvey, and you have full control over who's included in the survey, how you design the study to be able to answer the question you want to answer. But oftentimes that's not feasible. And briefly, there are three main reasons I think of that you would not choose to do a community-based serosurvey, and you would choose to do an alternative study design. And so the first is cost. So yesterday, Simon Mutembo highlighted that community serosurveys are expensive, and there are alternative designs that can lower the cost substantially, particularly by removing the cost of fieldwork. The second reason you might not do a community serosurvey is time. So we know from planning the serosurvey to data collection to data analysis, it takes a lot of time. So if you need answers about seroprevalence very soon, and an example would be the SARS-CoV-2 serosurveys, an alternative study design might be best if you're able to answer the question you need to answer. And then maybe the third reason is that you wouldn't do a community serosurvey is just the effort it takes and the importance of sustainability of that method in the future. So if your goal is to set up a more sustainable long-term surveillance system, then there are better designs than community serosurveys to do this.
Thank you, Kyla. My next question is for Andrea. Andrea, what are the most common alternative study designs that could be used other than community-based serosurveys?
Yeah, thank you, Charlotte. So at the high level, I think, as Kyla mentioned, for community-based serosurveys, you're going out and you're collecting new specimens. So when we think of alternative study designs, we try to look at where are there specimens that have already been collected, right? So some examples would be either a biorepository that might exist with specimens either from another survey or, for example, a blood bank. And another option could be to use residual blood that's being collected either in a lab or a clinic that might have leftover specimens after the original testing is complete. So we know that people come and they get their blood drawn to test for some routine things like iron levels, and there might be some blood remaining that you could use as an alternative.
Kyla, could you tell me how you will use residual or leftover blood in a serosurvey?
Sure. So with leftover residual blood, like Andrea said, so at a clinic, if the tests have already been completed for the reason that the blood was collected, this blood might be thrown out. We have looked into various ways of doing this, and this is a really important area of research for IVAC because our goal is to understand how to improve the utility and feasibility of serosurveys around the world. So one approach that we've done is in Zambia, there was a massive, extensive biorepository collected for the FIA studies, or the ZAMFIA project, which was estimating HIV prevalence throughout the country. It was a nationally representative survey, ideal setting. All the specimens had been collected. There was ethical approval to use those specimens for additional testing. And so we were able to partner with the ministry and test the residual blood for antibodies to measles and rubella to understand seroprevalence in the country and levels of protection against measles and rubella. So that's a very unique circumstance. And if there are biorepositories available where you work, it's worth looking into them. Second, what might be more common is accessing residual blood from a clinic or a laboratory. And in India, where our team has worked, we wanted to look at, could you evaluate the impact of a measles and rubella vaccination campaign on seroprevalence? How much did the seroprevalence increase after a vaccination campaign by using easier to access blood? And so in that case, we worked with the district health facilities and collected leftover blood from both pediatric and adult specimens, and were able to test those blood specimens. So those are two highlights of alternative designs that have worked very well.
Thank you very much, Kyla. What are some considerations for using residual blood from a hospital or laboratory for a serosurvey? This one's for you, Andrea.
Sure. Yeah, so I think as Kyla mentioned, we were able to do this in India, but I think the key aspect when you're considering this type of study design really is, what is the study question that you're trying to answer? And using that, then you can think about, is there a lab or a clinic that has leftover blood that would be appropriate to use to answer that study question? The challenge is that we're usually looking to sample from people that would reflect the general population. However, the people that are going to a lab or a clinic are often going because they're sick and they're not necessarily healthy. So we need to make sure that they represent the population that we're trying to sample from. So for example, one common source in many countries is to use residual blood from antenatal care clinics because pregnant women are having their blood drawn for routine preventive care and otherwise might be generally healthy and represent the general population. So for example, if we're interested in assessing the susceptibility of adults to rubella or to tetanus, these antenatal care clinics would be a good source. By contrast, when we're trying to study children, it's a little bit more challenging to find a representative sample because children tend to only have their blood drawn when they're ill. So these are just some things to think about when you're trying to use a lab or clinic for residual specimens.
Thank you, Andrea. And talking about residual blood from a lab or a clinic, Kyla, what are the most important challenges you think of when you do that, and what could be the implications for the results?
I would underscore what Andrea just said, and that I think the most important challenge in finding sources of blood specimens for serosurveys is ensuring that those blood specimens represent the population that you want to study. So you need to ask yourself, what is the population that I'm interested in? And then if, let's say, you're going to work in a district hospital where there's blood from the serology lab, do those samples that you can access represent the population you're interested in? How might they be biased? Who do they exclude? Why were those specimens originally collected? And one thing to really consider is, if they were collected for a reason that was related to the outcome of your serosurvey, you might not want to focus on that population. So for instance, we know HIV positive individuals, there's an association between HIV status and measles serostatus. And so if you're working in an HIV clinic, collecting residual blood from there, you may not get a representative estimate of measles seroprevalence by working in that clinic. And you may want to have a broader range of the population. Another challenge just to keep in mind when considering residual blood is that you cannot get all of the data you would normally get if you did your own standalone serosurvey. So often you can only get age, maybe gender, and often that's enough. But I just want to highlight that you're not going to usually get vaccination history data or maybe other socio-demographic characteristics that could be important for your analysis. So consider that. And maybe the last issue to think about for challenges, which is also a benefit, is that you need to integrate within the healthcare system. So it can be challenging because you don't want to take people away from their primary responsibility of taking care of their patients. But if you can set up a system that's sustainable, then it's more likely to continue and be lower cost.
Okay. Thank you, Kyla. My last question is for you, Andrea. What are the ethical issues of using residual blood? We had lots of questions yesterday on ethics.
Andrea is
Andrea, please, you're muted.
Sorry, yes, I was on mute. So I think one of the biggest considerations that Kyla mentioned earlier is that in order to do any testing on someone's specimens, you would need to ensure that there's permission and consent, right, to do the testing. So if you're using residual blood, you'd need to make sure that there was the additional permissions that allowed for testing beyond the original intent. So I think that's really the primary one to ensure you have before you can access a residual specimen. The other thing Kyla just noted, often you don't have all of the information for that specimen. So it might be anonymized, which means you wouldn't be able to report any results back to the participant. So you'd want to make sure that whatever you are testing for isn't something that would be that would affect the participant's health. So for example, you probably would not use residual specimens to test for HIV because this is something that you would need to report back to the participant to ensure that they're enrolled in treatment if they were to test positive. And these ethical issues can be addressed in partnership with the whatever lab or clinic and the system that you set up. As Kyla mentioned, I think working closely with the lab or clinic and really integrating with them, they understand best what are the implications for their populations. So those are two things to think about, but we could expand more if there's additional interest in other ethical questions.
All right. Thank you very much, Kyla and Andrea, for answering my questions. Over to you, Reda.
Great, thank you, Charlotte, and thank you, panelists from IVAC, or I should say CAST members from the International Vaccine Access Center. All right, there's been quite a bit going on Facebook and YouTube today. I think there may have been a glitch on LinkedIn, but that is less important than the fact that we have some regulars, and I want to share their comments with you, with the IVAC team. I also want to open up for questions. So if you have questions in relation to serosurveys, and specifically, even better, if they're with respect to today's episode, alternatives to community-based serosurveys, please type them into the comments, whether you're on Facebook, YouTube, or anywhere else. I do want to share, and it's actually this, I'm going to put the panelists on just to acknowledge some of the comments we've been receiving. So let's see, we've got, and I see some names that we've seen that were also with us during previous episodes. So Daniel Haruna from Abuja, Nigeria. Hello to you and thanks. I hope you're still with us and that you're typing in some good questions. Ruth Olote connecting from Accra. Our very own Tanushri Mandal, who says, loving the Serosurvey series. Therefore, sorry, this is the last episode. Wish more to come in the future days. Dr. Puran Sharma from Darjeeling in West Bengal, India. Amel El-Tahir connecting from Pakistan, Mercy Onu-Peters, who's also been on other episodes. Tanushree says, I was very pleased to know about the serosurveys done pre and post MR campaign in India and the objective of doing serosurveys in Zambia. Wonderfully explained. So that's feedback for the panel. Burema Kabore from Burkina Faso has joined us, as well as Dorothy Lojedi from Kenya. Joel Kudu connecting from Ivory Coast, and Mary Goretti Akini from Kenya. The 4-part series is awesome. I have gathered a lot from the presentations. Thank you. And do tell us also, praise is nice. If you see ways in which we could improve, that's also much appreciated. Dr. Eke Hudu from Abuja, welcome to you. Dr. Abidemi Olatunde, who's back today. This is good afternoon. Good to be here. Endayo Iwat, unfortunately, I'm not going to show your message because you have included some personal information in your message. Abdeladif also says, great presentation. Now, we have a first question from Tanushree Mandal, and I encourage you to type into the comments. Put in your questions. We're going to be sharing them with the panelists. We only have we're already over time. We're going to take a few minutes to see what questions are coming in today. Tanushree wants to know, for serosurveys, what is the sampling method employed? Yes, and she's typed in her question from Facebook and YouTube. So what say you, panelists, in answer
I can get started.
All right.
And so I think there's two different approaches. So one, the community-based serosurveys, the sampling method, we would recommend following the WHO cluster survey manual guidelines for doing multi-stage surveys, and they're directly applicable to serosurveys. Now, for alternative study designs, like using specimens from a leftover at a clinic, you can't choose how many samples you get. You get the samples that are available in the time frame that you need to work. So what you really need to do, I would recommend that you learn about the clinics where you think you may be able to work, identify how many specimens are collected each day, what's the rate of collection, what's the age group, and so you understand how quickly you would be able to accumulate your specimens, and then evaluate for your classic sample size calculations, can you answer the question you want to answer with the precision that you're hoping for in the time frame that you have working with that clinic. And you may increase the number of clinics you work with if it's insufficient.
Great. Any additional comments, details on what sampling method is employed for serosurveys? And again, the reference to the WHO cluster survey manual, type that into Google. You should be able to find the full manual is available from the WHO website. Any additional comments or details to add in response to Tanushree's question?
Maybe I'll just add, Kyla talked about if you're trying to work in the lab or clinic. I think the other study design we've talked about today is using a biorepository. So there, your cap is obviously the entire biorepository, but you can subsample based on, as Kyla noted, doing a classic sample size calculation with what is the precision that you want, what's the point estimate that you're trying to get, and then identify whether that biorepository has sufficient samples for you to be able to answer the question you're looking for.
Great, thank you. So we have another question. This one is from Mercy Onu-Peters, who asks, can serosurveys be classified as e-health or m-health?
Maybe I'm going to ask you, Rada, can you distinguish e-health and m-health for me?
I'm not sure. Mercy, can you tell us? So there's a slight delay, so we won't be getting the answer from her right away. But that's, I believe it's mobile and sort of digital or electronic, right? So one could be electronic, but not while being stationary in an office on a computer. I get Mercy, if you can tell us in the comments. And I also want to acknowledge other folks who've joined us. Tahami Rabiu Abdullahi, Anish Shah, who says, hello, everyone. Tahami actually says, nice to meet you. Nice to meet you as well, Tahami. Glad you can join us for this final episode. And Abdul Arif just says, thanks. All right, looks like, okay. Mary Goretti Akini says, tell me if you consider the blood group when sampling.
I can start. That is a good question.
I was going to say, that sounds like a Kyla question.
We have not assessed blood group because we don't consider it and are not aware of any that it's a risk factor for affecting the outcomes that we're interested in, measles and rubella or tetanus seroprevalence. However, in experiences working in Kenya and Mozambique, there's often an interest in the participants finding out what their blood group is as part of the process. So that may happen, but for research purposes, we have never used blood group.
All right, thank you. Been a great panel, a great cast of characters for this mini-series. The first time we've ever done anything like this. This time on Serosurveys in collaboration with the International Vaccine Access Center that is really a center of excellence in this area and has just issued the Serosurvey tools. So that's serosurveytools.org website. Quite an important resource if you're interested in this topic and would like to go further. I'd also like to point those of you who are watching online who have not yet attended the special event that we did in the summer. We've been rerunning it, and you can catch the next showing at 4 p.m. today, Geneva. If you go to learning.foundation and then go to special events, you'll find the Serosurvey special event. There's also a list of resources. You'll recognize some in the cast from the mini-series were also in the special event. And then here you have what's really important is here you have a list of references with links so you can find more if you'd like to explore further. That's it for today. Thank you. And this wraps up our 4-part mini-series. Let us know what you thought of this experiment. And thank you, Bill Moss, Kyla Hayford, Andrea Carcelan, Simon Mutombo, and Elvira Hassan for being a part of this and helping to share your expertise on this topic. Final comments from each of you before we go? Will do.
We want to thank you, Rita, and the Geneva Learning Foundation, and for your wide network for participating in this. And we are looking forward to future lightning talks on Serosurveys.
Great. All right. Thank you so much. And for those of you watching online, we know we'll see you soon and look forward to keep engaging in this conversation, this type of dialogue. Let us know what you found most useful about it. Thank you. Now we'll do the rewind of the comments. Some of the comments received